Hi, I'm Tamara, and this is TELUS Talks with Tamara Taggart. Hi, everyone. Today, super excited to be speaking to Dr. Tyler Black. Dr. Black is a child and adolescent psychiatrist and suicidologist who has been in clinical practice for over 12 years. Dr. Black, it's good to see you.
Thank you for having me. I appreciate it.
Now, is it okay if I call you Tyler?
Please do.
Okay. So I discovered you on Twitter pretty early on in the pandemic, and I really appreciated hearing about mental health and children from a professional, because I think we all know that, when we're getting news from social media, it's kind of like everybody's a reporter, everybody's an expert, and so it's really hard to find the people and where to get the information. I mean, let's just start there with you're quite vocal on Twitter, and you're very open with the data that you receive.
Yeah. It's just by the nature of my job, I work primarily as an emergency child and adolescent psychiatrist, which means I work in situations in which children are brought to hospital or hospitalized with significant psychiatric, family, social, drug crises. And so just because of that, I've always had to have a very pragmatic approach to what data tells me. Like, there is no journal article that tells me exactly how to manage a family situation in which a child is, threatening suicide because of a fight over bedtimes. But I have a hierarchy of information that comes to me, and then I have to use common sense and interpretation and lots of things that I try that work and that don't work. And everyone else has the ability to say, oh, send him to hospital or send them to a psychiatrist. But when that happens, I'm the person in that situation. And so I have to make decisions. So I'm often in a data poor, but idea high, charged emotional environment. And that's my common clinical situation. And that's what led me to being interested in suicide and suicidology generally, because it's a very important topic for people in Canada, one of the leading causes of death. But it's also allowed me to recognize which messages work for distressed parents. If there's one thing that I've developed really expert clinical skills in, it's that it's helping to communicate important information about mental health to distressed parents. And so I've tried to do that on Twitter a lot.
We're hearing, I shouldn't say that. I shouldn't say we're hearing. There's a lot of commentary out there that suicide is at an all-time high since the pandemic began. Suicide in children, it has never been higher. Our children are suffering, their mental health. Are these things that we're hearing true?
Well, it's a great question. I'd love to say definitively what the answer is, but I know what the moral panic is. And a moral panic is when society believes something, and then everybody says, let's look for the research for it. And then research is done. The research that supports the fear is amplified, and the research going against the fear is completely ignored. People wield that research, especially media and politicians, because it supports the fear. It's popular messaging. So the person who says your children are about to die of suicide because things are so stressful gets all of the clicks and all of the, everybody tunes to them and everybody listens to them, and lots of people really, really resonate with that message because they're worried about it. But then the person who puts up their hand and says, actually, there's this data that shows that things aren't as bad as we think, gets almost completely ignored, both by media, politicians, and distressed parents. And so, what I tend to find is the moral panic has been defined before the evidence came in. So I was reading articles in March, May, June of 2020 talking about the impending tsunami of child suicides, or the shadow pandemic that will inevitably follow the pandemic. And I was always like, hold on. We typically do our worst when we try to predict suicide outcomes, when we try to predict mental health outcomes. It's probably best if we follow what the data is telling us. And so when you ask me sort of what's the truth, I'd say There's certain things that I can say with a high degree of confidence that are likely true. For example, we're all under a tremendous amount of distress during the pandemic, and kids are not immune to that distress. They are receiving it full on. Distress is a little bit different, though, than mental health conditions. Mental health conditions usually require a diagnosis, some form of functional impairment, some longevity, such that it's not just a cross-section in time. And then, in that, are we seeing increased levels of disorder? I think the evidence is a little bit more shaky. I think because we're home more with our kids, we're seeing more, but we're not necessarily creating more. There's also that issue of separating what the pandemic has done and what other things during the pandemic, like lockdown and those types of things. And then finally, what I see wielded the most is this threat of suicide and death. More kids will die by suicide because of lockdowns, for example, than would ever be prevented of deaths from COVID, is a common kind of rhetoric I hear. And so when I look at that evidence, we have actually lots of evidence to show that kids actually did their best at the most severe first phase of the pandemic with respect to suicide outcomes and suicide attempt outcomes. So it's a mixed bag. And I think one of the reasons I've gained some resonance on Twitter is because I try really hard to display the nuance of the conversation and avoid this idea, are kids doing better or worse? Because I've worked with kids who thrived during the pandemic. No school to go to, lots of school to do. Their academics have never been higher, and they're not being bullied, and they don't have to worry about their social anxiety. They get to just be them. And then I have other kids who are socially tied in, who are really athletic, who've really missed sports, and they've suffered. And so there can't be a truth on are kids doing better or not, because it really comes down to, which kid are we talking about and what's going on for them.
I saw you posted something a while ago, and I can't remember what it was about, but you pointed out how many children have lost their parents in this pandemic and what that does to somebody's mental health.
It's one of those bits of nuance that it's not actually nuanced. It's just as soon as you bring it into the room, it adds the nuance. So people often have this binary of kids going to school or not going to school, kids on lockdown or not on lockdown, or what we're doing, kids wearing masks or not wearing masks. And it becomes this argument about what's best. And then I see mental health get brought in, but then this total lack of discussion of worldwide, we're probably at about 2 million kids who've lost a primary caregiver, a caregiving grandparent or parent in their life. And when I think about the mental health impacts of that, we know that that's very devastating. In fact, should one of our kids in a class know of another classmate whose parents died of COVID or whose grandparents died of COVID, that would be devastating secondarily to the child whose parents died. That would be devastating to an entire classroom. And so sometimes I feel like we're arguing about maybe the most minor of mental health impacts. During the pandemic, school has not been the same as when the pandemic wasn't in. And during the pandemic, home hasn't been the same as what it was before the pandemic. And so I'm not sure that the answer of going to school or not is the most important one in mental health. I think to me, I've sort of lined up around the idea that the sooner we end the death and dying of the pandemic, the better our mental health of our kids will be. And that to me is kind of the conclusion that I think a lot of people are just, they know it's probably true. And when I say it, I think it sounds truthy, but we can't accept it because that means we probably have to be more significant on our efforts to mitigate it. We have to go more Taiwan style or New Zealand style than what we've done. And, I guess I think a lot about that and how all these arguments about, children might not learn because masks make it hard for them to see their teachers' mouths move. Okay, sure, maybe I could make an argument for that. But then 1.5 million kids worldwide have died. And probably at this point, since the report was released, we're like 2 million parents of kids, caregiving parents and grandparents have died. It just seems like that's the bigger issue.
Yeah. When you put it out like that, 100%. I think that a lot of people don't think about that because it's not their direct experience. Whatever they are experiencing, sometimes we think everybody's experiencing the same thing, and it's just not true.
Yeah. I I have a phrase that I use, and I'll make it PG for the audience, but children are incredible antennas, but very poor receivers. They pick up on everything. They have this sensitive piece of equipment that lets them know when mom is upset. It lets them know when teacher is worried. It lets them know when the world is scary. But they have very poor receivers. What does it mean? And that can be really distressing. Kids will misinterpret these things all the time. And so in this pandemic environment, I'm in BC where there's been open schools most of the time. And often I'm having heated conversations with people in Ontario who are blaming lockdowns for all of their children's problems. But I'm in BC where schools have been open, and I've talked to schools, and schools are distressing places to be right now. There's constantly the threat of closure. There's constantly kids and friends and teachers getting sick and coming back. There's some people who are getting very sick that people are worried about. And then there's all the academic pressures and all the other social pressures that come with school without sports and activities. And it's just, it's a stressful environment.
Mm-hmm. How do we know if our child's mental health needs attention, medical attention?
Mm-hmm. I think, there's kind of a baseline in which our kids run, and most parents have a sense of who their child is. We all know that some kids are more introverted and extroverted, gregarious and thinky, and some kids, when there's a problem, they'll externalize it, and other kids will really internalize it. And you kind of get a sense for who your child is. To me, it's always worth medical sort of attention when there's a significant change in who they are, like the personality type. So the kid that's normally gregarious all of a sudden isn't saying very much, or the child that's usually quite introspective is lashing out a lot and being very, very irritable. And then function really matters to me. So the child that isn't doing what they would normally do. One of the harbingers of significant depression, anxiety, and other psychiatric problems would be a bored child. Children are supposed to have fun. And when they're not enjoying themselves or having fun, there's probably something amiss. The pandemic's been boring, but kids can occupy themselves. I mean, you give a kid a piece of paper and a pencil and they can draw. But, whenever I hear about a child being really bored, most of the time I've talked to kids who they just sit in their room and stare at the wall. And that's really abnormal behavior.
I think that, as parents, we, well, I can only speak for myself. I worry all the time, right? There's always something to worry about as a parent. So is it, and I don't like to use the word normal, but let's talk about typical behavior. Is it typical for a child to maybe say to their parent, I thought about dying, and should I be worried about it? Like if they talk about dying, or if they talk about, I'm just trying to get a sense from you of what is some typical language that we should know is no need to panic, parents.
Well, if we ask kids on a survey between the ages of 12 and 17, have you ever considered suicide? 15% will say yes. And so to pathologize that as abnormal would be really problematic. Only a small fraction. I think in Canada, 0.004% of children in the same age range would die of suicide. So thinking about it certainly doesn't predict doing it. But thinking about it can be really normal. It can be an escape mechanism we think in our brain when we're feeling really overwhelmed. We just imagine how much it would be better if we weren't around. Sometimes when we feel very low about ourselves, we imagine that we're different people, and that can lead to the thought of rather not being here. Of course, children at sort of teen years go through quite an existential crisis. Why am I here? What's the point of all this? Why do I have to go to school to get a job? This sounds like I'm just part of a treadmill. There's that normal stuff. And then we have the younger kids. The idea of suicide is not new to them at an early age. Like kids understand death and dying. The word suicide is well known by grade 3, grade 4. And what tends to happen over time is as kids start wrestling with the permanency of death, it becomes this thing that we all think about. I mean, every time we put on our clothes and we go out the door and we put a smile on our face, we're avoiding our impending death. Death is 100%. It's a major stress in life. but kids get aware of it. They can talk about it. Other kids can talk about it. So it always matters what's the context of the conversation. If your child were to say, "Oh, today I had a friend who was sent home from school because they were feeling really low and they had suicidal thinking," what a great opportunity to talk about mood and those types of things and not be too worried. But I would say, new distressing thoughts, it's always a good idea to think, and how can I help you? And one of the ways you can help someone is connect them to someone who they can talk to that's objective. Kids will always try to protect their parents, especially the more introspective kids will see that, I don't want to make my mom worried about that. She's already stressed about finances or whatever it is, and not talk about the stressful stuff. And so sometimes when that comes up, you can just connect.
Is it difficult to find someone? So let's talk about access to care, access to, finding your child or yourself, really. We're talking about, kids and adolescents right now, but I know as adults, lots of adults have a hard time finding a counselor, a therapist, a psychologist, a psychiatrist. They don't have enough money, or, they can't get in. Is that the same with children? Are we finding it's very hard to find someone?
Yeah, I wish it wasn't. Canada has some principles around healthcare that are supposed to be universal, but it can be very challenging in some jurisdictions to find mental health care for your child. I think, there's hierarchies. A school counselor is baked in, and they do have some guidance counseling and some psychological counseling abilities, but obviously will tap out very soon of their comfort level of managing significant distress. But always a really good basic option if you're worried. At least they would know the system and they've navigated it before. So they can be a really good touch point for parents, and they're attached to most children. In my jurisdictions in BC, every mental health center in every jurisdiction in BC has drop-in times where you can present your child. During COVID times, it's usually make a phone call and set up an appointment and you'll be seen. Unfortunately, that's not always tied to rapid access to counseling and follow-up, but at the very least, you can get that process going. Unfortunately, in my line of work, I do see a lot of kids in the emergency department who have not yet accessed care that should be available to them for lots of barrier reasons. And we still run into this problem in Canada that we have really wrestled with, where a lot of our help is 8 to 5 when kids are both either at school or parents are at work. For some parents, it's very easy to take a day off work and bring your kid in to see the counselor, especially when counseling is weekly. For other parents, that's the difference between food on the table and not. And we still have a really, really strong lack of evening or weekend services for kids. And I think that's an area that needs a robust protection. And all of this stuff is stuff I was talking about before the pandemic. So none of this stuff it's because of the pandemic, or, we're stretched because of the pandemic. These are all pre-pandemic issues that the pandemic easily exposed. Mental health was in a really good position to go virtual. We're probably the easiest of the medical specialties to go virtual because most of what we do is talking and interacting. We ran into really long waitlist problems pretty quick. And it wasn't an overwhelming amount of volume, or it wasn't a whole bunch of new kids. It was that the system was already taxed and struggling to provide what it could.
So how do we fix that, Tyler? How do we make it so that it's accessible, and how do we normalize, reaching out to someone to talk to them?
I hope there's a multi-pronged societal push. What I often see is mental health is kind of talked about in crisis moments. There'll be some kind of violent occurrence and someone with a mental health concern was involved, and all of a sudden there's a discussion about how we need more mental health supports. Or during the pandemic, it's actually been quite a topic. We need more mental health supports, but we need more people doing it. We need mental health to be better funded. We need more services with more avenues to access. We need services that target those who need us the most. Lopsidedly, it's easier to see a drop-in therapist for an anxiety problem than a child with severe schizophrenia, so we have these access issues. And I think what I'd love to see is it move from just the medical side of it, where how do we create more medical points or more counseling points, to also how can we introduce a full years-long mental health curriculum. And when I think about what's one of the roles of schools, it's to give you the education you need to be a good, successful adult. And they get lots of really good information on math and science and all these types of things. And yet we still run into this thing where mental health is an assembly. Suicide is like a half-day conversation. When really, you think about it, a lot of the things schools do are counter mental health. Perfect attendance. What a horrible thing to shoot for. If who among us in the adult world hasn't taken a sick day because we didn't feel like going into work, let alone actually being sick? We've just took our own mental health day. So there's lots of things I think could be added to schools. And I'd love to see parents become these advocates that put political pressure on those who could, to start like fundamentally addressing the root causes of mental health challenges. Like, this will sound very airy and, unrealistic, but ending child abuse would do a lot to stop mental illness. Ending child poverty would do a lot to stop childhood mental illness. And these are huge goals that a psychiatrist or a mental health team could never accomplish. So, this is a multi-pronged societal approach. And it always kind of feels like the answer is send them to the therapist. And it's like, what is a therapist going to do about all that stuff?
Mm-hmm, mm-hmm. Yeah. It's interesting because I feel like we as a society, we know what the answers are. You said it sounds airy or whatever, but it is true, right? To the root cause. We know how many kids are living in poverty in each province. We know, we have the data. Every province does. What are we doing to fix it? Yeah. And access to care for people, because what's easy for one person is very difficult for another person. I just want to mention here, this conversation is fantastic, and it's I'm already learning so much. But on this show I just want to mention, because you chose an incredible nonprofit for us to give $500 to on your behalf for spending some time with us. You chose the Indigenous Physicians Association of Canada, and they advocate for Indigenous people's health and acts as a support mechanism for Indigenous physicians and students. I'm really happy that you chose them. I have never heard of them, but let's talk about that for a second. Let's talk about Indigenous peoples and their access to the healthcare that they need in each province. Is it a bigger challenge? We've heard about suicide with young Indigenous people across this country.
One of the worst things about that is in the education side of it, is that it's often taught to doctors and clinicians as if being Aboriginal or Indigenous is a risk factor for suicide, when it is not. Indigenous people are overrepresented in suicide numbers. There is nothing inherent about being Indigenous that leads to suicide. There is everything inherent in systemic racism, having your land stolen from you, having your heritage stolen from you, being the victims of residential schools, having poor access to jobs, having discrimination when applying for jobs, having a harder time with education and discrimination in that leads to suicidal outcomes. And in fact, there are many Indigenous groups that display suicide rates lower than the average Canadians. But of course, unfortunately, we still live in a system where Indigenous people have a very far bar that they have to go over that non-Indigenous people don't to get access to services. It's tough. The provision of services in for example, a province like BC is challenging just logistically, but it doesn't take that away that it's a problem. So, not to make it sound too, not to be too dire about it, but someone who's Inuit in Canada has about a 10 to 14 times risk of dying by suicide, not because of anything about them. Their rate of suicide is 140 per 100,000 per year, when the average Canadians is around 11 or so, and this is entirely not due to any risk factor in them, but entirely due to how society and structure has been set up around them. So, I look forward to seeing more and more robust initiatives out of First Nations Health Authority. I hope we can actually not just signal how important Indigenous things are, but actually make it a thing. One of the reasons that I chose this charity is because every single medical association in Canada is underrepresented of Indigenous people, whether it's surgeons groups or psychiatrist groups or whatever it is. And of course, if we're going to provide healthcare and we don't actually have representation of Indigenous people amongst our ranks, how will we ever address that inequity? We don't come from that background. We don't have that perspective. We don't hear that voice, even in our own professional discussions. And so IPAC is such a great organization because they work really hard to reduce barriers to make sure that people who become physicians are more likely to be Indigenous, and people who are Indigenous are more likely to be supported as physicians. And it's a great organization.
Yeah. Well, thank you for choosing them and for telling us about them. I mean, there's so many things that I can talk to you about, and we'll have to do this again because we're running out of time, and there's just so much to talk about. And I really want to give, you speak all over the world, and I guess that's changed for you too, right? You're probably doing that more online now if you're still doing those things. Yeah. What you speak about, suicide and suicide risk and assessment and emergency psychiatry, pediatric emergency psychiatry, video games and violence. I mean, we could talk for hours probably about that.
Yeah.
What worries you, or what keeps you up at night? Or, I mean, I want to know from you, like, what do you think, where should we be focusing our advocacy for others? Or, you know what I mean? Like, I really want to know what your concerns are,
Yeah. The two, I would say, like, there's two main things that I think about the most when I think about the challenges that I face that just seem always unaddressed. When it comes to, access, I always think a lot about how hard it is for someone with severe mental illness to access care. And people will, I know there's a shared experience of mental illness. I know that lots of people go through anxiety and depression, but there is this hidden group of people with just absolutely debilitating schizophrenia, obsessive compulsive disorder, depression, agoraphobia, can't leave the house, 1% to 2% of the population with intellectual disability and genetic combinations, neurodiversities that rob people of things that they could otherwise do. And a lot of our clinics will have exclusion criteria for things like, we treat anxiety, but not if you have an addictions problem. And then the addictions program will say, we love to treat addictions, but not if you're suicidal. And then the suicide programs say, we'd love to help you with your suicide, but you need to conquer your addiction first. And the person with significant struggles with addiction, severe mental illness, ends up not getting help. And I think a lot about how our system has designed just to almost as a way to protect themselves from being overwhelmed, because it would be overwhelming. But almost every system has a bunch of exclusion criteria that keep the people who need us out the most. And one of the nastiest parts about exclusion criteria is if you know that, your systemic discriminations will come into play. It'll be more likely that you'll have a reason to not have the Indigenous person amongst your clinical role. It'll be a reason that you can't help that person who's had a violent history, because, you can just flex your exclusion criteria. And really what you're doing is you're creating systemic discrimination, but it's against a group of people with severe mental illness. And then worse, extends into a group of people that you just aren't comfortable treating. And I truly believe that group of people is under addressed. And then I think a lot of people who have, some anxiety or some, challenges have a much easier time accessing help. And I always think that's backwards. I think psychiatrists and mental health professionals should be focusing on those who need us the most. And we can leave the person with, occasional office-based anxiety to the yoga gurus and all the other non-specific things that we know work. Not that therapy isn't helpful, but I just don't understand why the most trained among us see the least sick. And I see that a lot in my practice because I don't get to filter who comes to the ER. I see everybody. And so many times the story that I get of a child in the ER who's really, really ill is we're on the wait list for X, or we can't see Y, or whatever. And so I think about that one a lot. The second thing that always just gets to me is how large the societal issue is, whatever it is we're talking about, and how much mental health is just othered in that conversation. When really people need ongoing sort of lifelong support. And I always kind of think back to myself. So I'll share this about myself. I'm very happy with my life. I like who I am and I do things that I enjoy. But I make very careful note whenever I talk about suicide to share that I could die of suicide. Tomorrow, my wife could tell me that she's leaving me for some reason. And maybe at a bad moment, I decide, you know what, I can't do this without her. I could be diagnosed with a severe illness that I know will rob me of my life and dignity, and maybe I'll apply for medical assistance in dying. Or I could be at the top of a burning building and rather than burn to death, decide I'd rather die by suicide. This idea that only other people do this thing, that is a universal escape mechanism for unbelievable pressure, I think in some way others it to the point where it always feels like when you're suicidal, it's shameful. And I have worked with, at this point in my career, more than 10,000 suicidal kids. And not once have I felt, oh, that's really unreasonable that you felt that way. And yet what they feel universally is this shame of, it's just me. No one else knows this. So I think that othering thing always affects me quite a bit because routinely for my patients, I see shame and parents. Parents will apologize for bringing their kids to see me. I'm so sorry for all of this that this has caused for you. And I'm like, this is my job. This is what I do. Why is there so much still shame?
Yeah, there is a lot of shame. Yeah, there is a lot of shame. And we do a lot of talking about, ending the stigma, but there's a lot of stigma. And
there's a lot of stigma that can only be a sort of overcome by putting ourselves right there with them. And if everyone who struggled, who was part of this stigma, knew that all of society was cheering for them and rooting them on, it would be one thing. But, unfortunately in this space, a lot of people feel like their lay opinions on what's going on for people is enough. And they haven't seen the situations that really get people to where they are. And every day I'm encountering a family that for the first time is encountering how stressful their family environment has been because now their child is overwhelmed. Right. But of course, it's not a new thing. So I think the less we other it, the better.
I agree with you. And I will say that if you're listening and you don't follow Dr. Black on Twitter, there's a lot of great information on your Twitter feed, really, truly. So that is at Tyler Black 32, the number 32, at Tyler Black 3232. Tyler, thank you so much.
Thank you for having me.
No, really, it's just so much information there and a lot to really think about. And I appreciate your time. I know you're busy, and I really appreciate you taking the time to speak with us.
You bet. Anytime. Thanks so much.
Thanks for listening to another episode of TELUS Talks with Tamara Taggart. Be sure to subscribe so you can join us every Tuesday for another conversation. You can also check out our website, telus.com/podcast, and subscribe to our YouTube channel at TELUS Talks.